Hey everyone, and welcome to this rapid high-yield explainer. Today, we're going to systematically break down the clinical pathway of a myocardial infarction. The real goal here? To make these critical protocols stick permanently in your memory. Whether you're reviewing this for your own clinical practice or you just want a really solid, structured understanding of cardiac emergencies, you are absolutely in the right place. We're taking direct clinical source material and transforming it into a clear, vital roadmap. Let's get to it. All right, let's take a quick look at our mental roadmap for today, which is structured to perfectly mirror a patient's journey. We'll cover 1, the 5 types of MI, 2, spotting the ECG changes, 3, the priority OANM protocol, 4, STEMI versus NSTEMI treatment, and finally, 5, interventions and complications. Starting right off with section 1, the 5 types of MI, we gotta start with the culprit. Before we can even think about treatment, we need to know exactly what's causing the damage in the first place. Imagine a patient walking around for decades. Plaque is just silently building up. Their arteries are slowly hardening. And then, suddenly, a rupture occurs. A staggering 90% or more of all MI cases are caused by atherosclerosis. It is by far the most common underlying mechanism you're going to encounter, really serving as the deadly foundation for the specific types of infarctions we categorize in the clinic. So while that classic plaque blockage represents a type 1 MI, the clinical picture is actually a lot broader than that. For instance, type 2 occurs when the plumbing itself might actually be okay, but there's a critical supply and demand mismatch. This happens when the body is under immense stress, think profound hypertension or massive sepsis, and the heart simply can't keep up with the demand. Then we have type 3. This one is tragic. It's categorized as sudden cardiac death. The patient experiences chest pain and passes away within 24 hours, meaning the clock literally runs out before blood samples can even be drawn to officially confirm the infarction in the lab. Moving into the procedural infarctions, type 4 MI is directly tied to percutaneous coronary interventions, or PCIs. Clinically, we break this down a bit further. It's 4A if there's no thrombus inside the stent, and 4B if stent thrombosis actually occurs. But you might be wondering, why do we require a specific spike in cardiac markers of 5 times or more above normal? Well, it's because a PCI procedure inherently causes minor, localized trauma to the heart tissue anyway. So to prove a completely new infarction has actually happened during the intervention, we need to see a massive, undeniable 5-fold spike. Now, if a PCI needs a 5-time spike, think about a CABG. You've just performed major open heart surgery to bypass a vessel. The baseline surgical trauma to the myocardium is immense. Because of that, your threshold for diagnosing a type 5 MI doubles. You absolutely require a 10-fold increase or more in those cardiac markers compared to baseline to definitively say, yes, a new infarction has happened. Okay, moving right along to section 2, spotting the ECG changes. We know the types, but how do we spot them in real time? Because when your patient is having a cardiac event, reading the chronological sequence of the ECG is everything. Put yourself in the room for a second. You're standing right over the patient's monitor. The clock is ticking, and reading the real-time progression is absolutely critical. Your very first red flag, the earliest sign of trouble, is a hyperacute T wave. Moments later, you witness that classic ST segment elevation. As the damage progresses and the ischemia deepens, you'll see T wave inversion. And finally, the event leaves its permanent signature, an abnormal pathological Q wave. That Q wave usually drops about 3 to 4 baxes deep on the ECG and remains there for the rest of their life as an indelible marker of an old MI.
But hey, the ECG doesn't work alone. While it's your real-time monitor, Troponin I is your absolute, indisputable gold standard. Troponin I is the single most definitive cardiac marker you can pull to confirm that myocardial tissue is actively dying. Which brings us to section 3, the priority protocol. You've spotted the clues on the ECG, you've confirmed the markers. Now, what's your immediate plan of attack when you're the primary caregiver in the room? The American Heart Association mandates a very strict priority sequence, OANM. But why this exact order? Well, oxygen comes first to immediately fight the underlying myocardial hypoxia. Aspirin is next to halt any further platelet aggregation. You got to stop that clot from growing. Then nitroglycerin to rapidly vasodilate and open up those starved vessels. And finally, morphine. That's to manage the severe crushing pain, which in turn drastically decreases the patient's overall cardiac workload and oxygen demand. I know, Mona has been drilled into our heads for years. Old habits die hard, right? But you really have to forget her.
MONA is just an outdated memory trick, and using it as a clinical priority sequence is a massive misconception. OANM is the definitive AHA-approved clinical priority order you absolutely must follow to properly stabilize your patient and save a life. No exceptions.
All right, Section 4, STEMI versus NSTEMI treatment. Once your patient is stabilized using that OANM protocol, the exact type of ST segment variation you noted earlier becomes super critical. This right here is the critical fork in the road for your patient, outlining exactly how your management diverges. For a STEMI, an ST segment elevated MI, the primary action is immediate thrombolysis, specifically using tenecteplase as the treatment of choice to bust that clot. However, for an NSTEMI, a non-ST segment elevated MI, you must administer strictly no thrombolysis. Instead, those patients should be moved directly to a primary PCI, like an angioplasty, to manually open the vessel.
And finally, Section 5, interventions and complications. We have to look at the surgical interventions required if the blockages are incredibly severe, as well as the long-term risks following the event. It's really all about a tipping point based strictly on the severity and location of the blockages. If a patient has divascular disease, meaning 2 blockage sites, you can manage that with a relatively straightforward angioplasty. But the moment you discover that 3rd blockage, trivascular disease, the rules change completely. You're mandated to bypass the extensive damage entirely with a full KBG surgery. So, let's recap. You've correctly identified the type of MI, read the ECG perfectly, initiated the OANM priority protocol, and selected the right intervention. Your patient is treated, but you must remain on high alert. After all this careful management, what is the single most likely fallout to strike next?
The absolute most common overall complication following an MI is a dysrhythmia. And if we want to get highly specific, the #1 dysrhythmia you're going to see is a premature ventricular contraction, or a PVC. If PVCs aren't present, the second most likely complication is sinus tachycardia. So we've mastered the plumbing and the immediate electrical fallout, but it leaves us with a really critical question. As medical technology continues to advance, what is the next frontier in preventing that initial 90% plaque buildup before this clinical pathway even has to begin? Food for thought. Thanks for joining me on this explainer, and I'll catch you next time.